Okay, once again, good evening and a very warm welcome to our webinar this evening covering treatments for knee osteoarthritis. My name is Phil and I'm your host for this session. And I'm delighted to be joined by our expert speaker, Mr. Raman Thakur, consultant orthopedic surgeon.
Hi, Phil.
Hi. Tonight's session will begin with a presentation from Mr. Thakur, followed by a Q&A session at the end, where we will take questions from all our attendees. If you have any questions, please feel free to submit them using the Q&A icon, which you'll find at the bottom of your screen. You're welcome to ask your questions anonymously, or you can include your name. Just a quick note that this session is being recorded for archiving, so any names shared may be visible in that archive recording. And we are keen to answer as many of your questions as possible, so to help us get through those, please can you keep your questions brief? That is very much appreciated. If you are interested in booking a consultation, we'll share all the relevant contact details for that at the end of the session. So without further delay, I will hand over to our expert speaker, Mr. Raman Thakur.
Thank you, Phil. Thank you for having me, and thanks to everyone for joining this webinar covering knee arthritis and the new treatments that are available in the fields. So I have started my orthopedic training back in India, in Hyderabad, and having completed my orthopedic training there, I came to England in 1992 and trained in the Southeast. After my completion of training here, I attended a fellowship in New York and became a consultant hip and knee surgeon working locally in Kent, and started in Pennenden Hospital since 2012. I'm a member of British Hip Society and American Academy, and my special interests include hip and knee replacement, robotic knee replacements, and ACL reconstruction. We will cover the following topics, taking from consultation through to discussion about some patient decision support tools, and then question and answer session. So first and foremost, the important aspects of understanding specific of individual patient would be the history, to really understand what started, how the onset happened, and two, how it has evolved, and three, how much trouble it is causing for the individual who is suffering from these symptoms, and then subsequently considering treatments, which would be both operative and non-operative options. Obviously, part of that non-surgical treatment will be physical therapy, and any restrictions on activities would become a part of discussion there. Subsequent assessments might need an X-ray, an MRI scan, and if surgery is contemplated, fitness for anesthesia. So knee arthritis is essentially wear and tear on the surface of the bone, and presents itself in most people with early morning stiffness, activity pain, gradual onset, and progressively getting worsening symptoms. It affects the ability to walk, and walking distances reduce, associated with swelling. Sometimes patients have further symptoms such as locking or giving way, and as the pain and a condition worsens, a patient may experience pain at rest, pain at night, and notice that their leg is getting deformed. As I said, it is inflammation in the joint causing breakdown of the surface of the bone. So look at a model of the joint, we can see that we are talking about the surface of the bone, and that is where the arthritis affects, and that normally smooth glistening layer gets worn out and the underlying bone gets exposed. And this could be both related to age, but also trauma, and post-traumatic arthritis can progress into osteoarthritis. Sometimes, though this is the most common presentation with arthritis, sometimes patients actually come in with an acute event. They've had a knock, a twist, an injury, and they have had no symptoms with the knee before, and they get sudden onset of symptoms. And when you explain to the patient that there is arthritis in the knee, it seems to be a bit of surprise and feel, how come arthritis has suddenly appeared in my knee? I think the corollary is similar to somebody having a heart attack, in that it is an acute event, but the problem has been there in the background, and gradually a narrowing of the artery, and with some critical ischemia or another event, the block happens and patient gets sudden pain. So similarly with arthritis, the body can accommodate and adjust and remodel things itself, but then an event happens and then it can become a sudden onset appearance and then gradual progression, and then it is not improving. So it may end up needing either operative or non-operative intervention for the arthritis. Just showing an example, a model of a healthy versus an arthritic knee. As I explained earlier, the surface gradually wears, exposing the underlying bone. Treatment options, we talked about non-operative ones, and in the first instance, most of the time it will be simple pain medications, analgesics or anti-inflammatory, and physiotherapy. However, if the pain and weight loss and activity modifications, but if pain continues to remain intrusive and not improved, then may benefit with a injection. We do 3 types of injections at Benenden Hospital: a steroid, a lubricant, hyaluronic acid, or an arthrosomid injection. From an operative point of view, if there is a significant deformity that is causing, and especially in a younger person, first thoughts might be to prevent or delay joint replacement surgery. And one of the ways of correcting the alignment and using the more preserved part of the knee would be an osteotomy and realigning the bones. Arthroscopy sometimes may be required, especially when there are loose bodies or in fact significant degenerative meniscal tear, which may be causing mechanical locking or giving way. Cartilage transplantation has been tried and is still having more and more research going into it. But when it is extensive arthritis, if it is fairly localized, it may work and it can help. But when it is far more extensive wear on the surface of the bone, then cartilage transplant may not be an effective option. And then comes the replacement options, where one can consider a partial knee replacement. This is a model showing this side of the knee and the kneecap joint have been spared, but the inner side of the knee has been replaced with metal, both on the femur and the tibia, and there is a spacer, plastic spacer, which has gone missing in this model. Or a total knee replacement, which would involve resurfacing the lower part of the femur and putting a metal on the lower femur, and similarly taking off the diseased bone and putting in a metal surface to the tibia with a plastic in between, then which articulates like so. And therefore, because the worn out bone is not rubbing bone on bone, the arthritic pain is relieved. As you can understand, knee replacement surgery and some of the other surgeries are significant interventions and have a prolonged recovery. Arthrosamid is a biodegradable hydrogel, non-biodegradable, so it stays in the body for a very long time. It is an inert hydrogel polymer, polyacrylamide, and which absorbs water and is about 97.5% water and 2.5% polymer. It is delivered by an injection into the joint, and once injected, it goes and into the lining of the joint, the synovial membrane integrates with it and reduces inflammation in the joint, reduces the inflammatory byproducts, which can cause further destruction and arthritis in the joint, and also increases suppleness of the soft tissues, reducing some joint stiffness, reduces pain, and enhances function. The benefits may take a while to happen. It is not as quick as sometimes a steroid injection. It may take anywhere from a month to 3 months for it to work. And if it has been effective, the benefits can last up to 4 years. It is done as a day case procedure. We give antibiotics orally as tablets an hour prior to the procedure. This is done under a local anesthetic and ultrasound guidance. Any fluid in the knee is drained, and the gel comes in as 6 syringes of 1 ml, which are injected, and we advise postoperatively is to take it easy for about 2 to 3 days to let the knee calm down and avoid strenuous activities for a couple of weeks. And there is a structured rehab program which is available even and supported by the company as well. Sorry, when I say supported, it is available as a booklet which can be handed to the patients. Sorry. Pain reduction following arthrosamid injection. There have been several studies, and this has been a constant observation that the pain decreases fairly significantly in about 70% of patients and can be maintained for up to 2 to 4 years in a couple of studies, which have been the longer term ones. The other ones finished at a year. Other options for injection include steroid injection, which is again an outpatient procedure, can be done in the outpatient clinic and can work between few weeks to few months and might delay any replacement for about 6 months. Can have 2 to 3 per year. And then the lubricant injection, which is the hyaluronic acid, is a single injection at Benenden Hospital, and it replenishes the dwindling and the ineffective hyaluronic acid in arthritic joint, helps with lubrication, and reduces pain secondary to reduction of inflammation. It may last between 6 months up to a year. It can be repeated after 6 months. Now, the surgical options, knee replacement surgery, over 100,000 are regularly performed in the country and have been since the past 2-3 years. Average age is in late 60s and slightly more preponderance of ladies compared to men. This is from the National Joint Register data. The idea is to help relieve the pain, restore function and mobility, and realign the knee and correct the deformity. The knee replacement we use at Benetton Hospital is Vanguard knee replacement, which is manufactured by Zimmer Biomet and has the highest orthopedic device rating of 15A. 10-year survivorship of this implant is 96.4%. It is performed and held to the bone using bone cement, which acts as a spacer, and can be performed with resurfacing the patella with a plastic, or sometimes without. If the knee cap is pristine, we don't replace it. This is a video, I believe. Let's see if I can let it run. Showing a knee replacement. So, talking about partial knee replacements, this is an option if the arthritis is restricted to one compartment. So, as I mentioned earlier, if there is no arthritis behind the kneecap or the outer joint, then the inner joint can be replaced. And similarly, we have partial knee replacements for the inner side, partial knee replacement for the outside, and partial knee replacement behind the kneecap. Revision rates are slightly higher in partial knee replacement, not because the prosthesis wears out quicker or it comes loose or anything like that. It is more because the arthritis progresses in the rest of the knee in future, and then it may require either a second partial knee replacement or a conversion to a total knee replacement. Damaged compartment is replaced with metal and plastic, leaving behind healthy bone and cartilage. The important point again here is, which you can see, is that the ligaments are untouched in a partial knee, especially the cruciate ligaments, whereas in a total knee replacement, definitely the anterior cruciate and sometimes the posterior cruciate ligament are removed to be able to allow the knee to perform nicely and to do the operation as well. So the recovery tends to be a bit quicker with partial, but again, everybody is individual, and this may not necessarily be true to everyone. ROSA is the robotic surgical assistant system and is by Zimmer Biomet. It is helps the surgeon in performing the surgery. It is like replacing some of the instruments with the robot, so we can reduce some of the steps of the operation. Because it is less intrusive with the robot, it is associated with a slightly less pain and a slightly shorter stay in hospital, and hopefully an easier recovery. But again, it is in when you look at percentage of people, it will be like 75-80% of people are much better recovery, and 15-20% are similar to a conventional knee replacement, having some more difficulty and the pain levels. Sensors are attached to the leg through pins. So there is a small additional incision on the lower leg where a couple of pins are attached, and sensors are then attached to that pins. The robotic arm guides the surgeon and helps position our cuts to help automated adjustment based on movement of the knee. And it is also now possible to do a partial knee replacement using the robot. So this is again a video replacement using the surgical assistant.
ROSA Knee is a robotic surgical assistant for total knee replacement. Your surgeon is specially trained to use the robot. ROSA Knee does not operate on its own. Your surgeon is in the operating room the entire time and making decisions throughout your surgery. Your surgeon creates a plan for your surgery based on your unique anatomy. The robot helps to ensure the plan is executed as intended. ROSA Knee uses a camera and optical trackers to know where your leg is in space. If your leg moves, the robot can tell and adjusts accordingly. ROSA Knee provides your surgeon with data about your knee. This helps to personalize your surgery based on your unique anatomy.
So the risks of joint replacements include damage to tissues, the nerves, the blood vessels, tendon, and bone are all, as you can see, around the operating area, and we take precautions to avoid secondary damage. In terms of recovery, we are talking about bleeding from the wound, wound ooze, wound breakdown, and wound problems, specifically infection, which may occur and show itself usually after the second week. Blood clots in the leg, clots going to lungs, ongoing pain and sometimes a limp, and swelling and stiffness of the knee. The swelling usually takes quite a few months to resolve. People expect that after 2 weeks, this knee will look fine, or the leg will look better, but you can still have some bruising. There is some swelling, and that swelling of the leg and the knee can take as much as 3 to 4 months to resolve nicely, and it may be up to a year before the knee appearance can actually look completely normal as the other side. Late complications include failure of the implants, either by loosening or wear, and fracture around the prosthesis that may require revision surgery. And apologies, you pressed the wrong button. So hospital post-op usually 1 to 2 nights, work with the physiotherapist and the nurses, get you out of the bed and get you walking, and then practice stairs. They will advise on how to get comfortable, how to work with exercises to improve the strength of the muscle and get the movements back. And most people discard their walking aids by about 4 to 6 weeks, and driving is usually after 6 weeks. So painkillers, and as I mentioned, ongoing bruising, and will be there in that first 2 to 3 weeks till the wounds settle down and the tissues heal, and 6 weeks for driving. Follow-up appointment is at 6 weeks, and most people notice or start noticing the benefit from the operation around that time and gradually getting stronger. It may take up to 6 months to return to complete normal activity, and sports such as golf or skiing would be much longer than that. Our hip and knee surgeons here at Benetton Hospital, who we are a good team, and we all work together, and more than happy to see you and help guide your management. I think that is it for me. Okay, just putting on the NJR data from the latest registry report. In 2024, there were 116 or 117,000 knee replacements, including partial and total knee replacements, and 92% of these were for arthritis and 4% for trauma. Whereas for the hips, there were 135,000 hips with not sure why unicondylar has been added there, but osteoarthritis again is a major 98%. Okay, so somebody has done a little this thing. So 116,000 were hips, and I think 134,000 were knees, because that includes arthritis and unicompartmental. So sorry, there's a little bit of this thing on the slide, but the hips and knees are reversed, I think. Sorry about that.
Okay, thank you, Mr. Tackle.
Over to you, Phil. Thank you.
Thanks. Lots of useful information to digest there, and we'd now like to move on to our questions. And we are very pleased, obviously, to have so many of you with us today, but it does mean that we may not be able to answer every question. We will do our best to cover as many as we can in the time that we have. And before I begin to go through the questions, you can see on the slide there's some guide pricing and information on arranging treatments. So, to our first question from an attendee, they ask, what is ACL, please?
Sorry to have used abbreviation without telling that before. ACL stands for anterior cruciate ligament, which is the ligament within the middle of the joint, running in the front of the posterior cruciate ligament. So there are two ligaments which run crossways. The one in front is anterior, the one in the back is the posterior cruciate ligament.
Great, thank you. This next question will test my pronunciation, but I'll do my best. This person says, I had osteochondritis dissecans, age 12, 2 pins inserted in condyle. Now age 66 with severe arthritis in both knees. I've been told by a consultant knee specialist that I'm not suitable for knee replacement due to my legs not naturally being straight. Would any of your treatments be suitable for me, especially in relation to the pins?
I would say that the best thing for a way forward would be for actually you to have a consultation with one of our colleagues and assessment, and we can get some up-to-date x-rays and look at your alignment, and maybe if there is metalwork elsewhere within the bones in your thigh and your uh, um, tibia, then you may be a candidate who's suitable for a robotic knee replacement. So it may be something that we can do as a various option, or possibly a conventional knee replacement, but only we'll know that once we have a consultation and an assessment. So that would be my first recommendation for that.
Okay, thank you. Our next attendee, Alistair, asks, is the arthrosamid injection painful, as I understand the steroid injections are?
So there is some pain in a very small proportion of patients during the injection, but majority of the patients, once they have had the local anesthetic, they are quite comfortable. The injection process itself is not particularly painful, and afterwards, because of the local anesthetic, they are quite comfortable for several hours. And the reaction to the gel does not necessarily seem to be as bad as sometimes to the steroids, because the steroid do have preservatives, and which sometimes can cause further inflammation and pain. But generally, arthrosamid seems to be a lot better tolerated than a steroid injection. So I feel that I haven't heard any patient come back and complain to me that it was extremely painful. No.
Okay, thank you. The next question is, can arthrosamid injections be administered to people with multiple sclerosis?
There is no contraindication for administering to people with multiple sclerosis. So the short answer is yes. It will just be determined on the level of arthritis and whether it is suitable, which can be answered through a consultation.
Okay, thank you. Next question, can a fused ankle joint affect the knee joint?
Absolutely, because it affects the biomechanics of the leg. But if the not necessarily if the ankle is in a neutral position, so but it does affect how the joint moves, particularly when you are walking. So the short answer is yes, but the long answer is it can still be appropriate to work with a fused ankle to consider any of the interventions related to arthritis in the knee.
Okay, thank you. Next attendee asks, you talked about 2 injections. I've heard of cellular matrix injections. What is this, and is this an option?
So it is possibly the platelets, or which sometimes are collected with platelet plasma as well, and injected into the knee to encourage repair of cartilage defects. But these are usually for small defects and do not really seem to be as effective if the arthritis is fairly advanced or extensive. So it might be an option in only selected patients.
Okay, thank you. What is the lifespan of a partial inner knee replacement?
So I would say that the prosthesis and the implant, the actual procedure itself has got no more significant failure rate than a total knee replacement. So there's still long-term failure rate is about 1 to 1.5 per year. But the reason why it fails is slightly different, and more often the failure is because arthritis has progressed in the rest of the knee rather than a problem with the implant. So whilst the usual complications of infection, loosening, wear are exactly similar to a total knee replacement, it is more often, as I said, and that probably explains why sometimes the partial knee replacement has to be revised.
Okay, thanks. Next up, we have a question from Mark, who asks, what anaesthesia would be used, for example, spinal injection or full anaesthesia?
So over 90% of my patients having either a hip or a knee replacement have a injection in the to block the nerves with a spinal anesthetic from the waist down, and sedation to keep them comfortable and not aware of the surgery. Full anesthesia is only done exceptionally, especially if the patients want to go and have a full anesthetic, but it is not necessary in most patients.
Okay, thanks. This one is an interesting one from Nicola, who asks, would arthrosamid injection assist a torn meniscus where the only issue is that the leg will not straighten? Pain has been eliminated through physiotherapy and strength building of muscles.
So the problem, why the knee is not straightening, is it because the torn bit of meniscus is stuck in the middle of the joint and stopping it extending? So in that case, it doesn't matter whether it's an arthrosamid or any other injection, that is not going to help a mechanical issue where the meniscus is stuck in the middle of the joint. If it is more due to pain and scarring and stiffness, then physiotherapy should most likely help. And if physiotherapy is too painful, then certainly intraarticular injection would be helpful to reduce the pain and allow the physiotherapist to work. I don't think an arthrosamid itself would be my first go-to. If at all I'm considering an injection, I would probably try a steroid as the first go in this scenario.
Okay, thank you. Next question comes from Kelly, who asks, could you advise me on the best injection to have for very severe bone-on-bone arthritis?
That is a very difficult question to answer, Kelly, because the problem is I don't have a crystal ball. There are options. The options here at Benenden are threefold. A steroid injection, a lubricant injection, which is hyaluronic acid, or an arthrosamid injection. Now, steroid and arthrosamid work in a similar fashion, but the arthrosamid, if it is effective and works, then it lasts a much longer time compared to a steroid. The lubricant is slightly different mechanism of action, but the effects can last up to 6 to 9 to 12 months. The biggest difference between the steroid and lubricant versus arthrosamid is the fact that both the steroid and the lubricant are removed by the body. And this will be similar for any other injections like PRP, cellular matrix, or whatever. The body eventually will remove those materials out of the knee. And whereas with the arthrosamid, the polymer, polygel stays in the knee for a very long time and is very inert, and therefore it continues to work. So that is the difference. But essentially, whatever has worked for you, and then take it from there where we go next. Yeah.
Okay, thank you. Question from Christine, who asks, what action can we take pre-operation to help faster or better recovery for knee arthritis?
So certainly working with the therapist to help keep the strength of the muscles in the knee. I think, keep the muscles stronger and in good condition will also help you carry on with the exercises post-op and help speed up the recovery. Just making sure your nutrition is good, making sure that having a healthy diet, all of those will certainly help again the healing of the tissues and faster recovery.
Okay, thank you. Next question. Excuse me if I pronounce this incorrectly. From Marika, looking at the name, but is arthrosamid removed if you have a new knee later?
So in a knee replacement, as we said, we are working with the bone and we are working to remove the bone surface where it is bone. The arthrosamid actually goes into the tissues lining the sides of the joint and the surface or the lining of the joint, which we move out of the way. So we don't have to go after the arthrosamid. The arthrosamid can still stay in the joint. Only if there is a lot of synovitis and inflammation do we actually go after removing the synovium. So in general, if patients come back with a ongoing pain and need a knee replacement after arthrosamid, it is not generally something that the surgeons will go after and remove the arthrosamid or the synovium.
Okay, thank you. Question from Kenneth. I'm 79 years old. Does my age increase associated risk of surgery?
Kenneth, age is a number. What is more important is how you are physiologically. If you are in good condition and good medical condition, then certainly it does not increase the risk of surgery. And I think that is the more important. If your health is good, you can have surgery. My oldest patient who had a joint replacement was 95 years of age, very active, still working 3 days a week and working, doing active physical jobs. So it is, as I say, it is not necessarily the age.
Okay, thanks. Can the arthrosamid gel leak out of the capsule and what happens then?
So when we inject the gel, we make sure that that's the reason for doing it under ultrasound guidance, making sure that the arthrosamid is injected within the joint cavity. It is quite a viscous gel. It will not come out of a little puncture in the capsule from the needle. So because that puncture usually seals itself with blood and a clot and then scarring. So the arthrosamid tends to remain within the joint, and that's why you can see some of those pictures which show that how it is integrated into the lining of the joint. So it is very, very unusual for it to leak out.
Okay, thanks. Alison asks, what is the cost of Durolane Visco supplementation, please?
If you are a member of Benenden Hospital, then for a member it is free for the first injection. If further injections, I think there is a cost for it. You can ring up the private patient team and they can tell you about that, please.
Okay, thanks. Next attendee asks, if a knee replacement lasts 10 years, would there be any issues in having subsequent replacements?
So there is I don't think there's an upper limit for how long a knee replacement can last. The important point to understand is the fact that knee replacements fail at the rate of 1 to 1.5% per year. So if you put in 100 today, in 10 years, 10 would possibly fail and 90 would still keep going. And in 15, 20 years, 15 to 20 will fail, and 85 to 80% continue to perform. So it is only when the knee becomes painful, has problems, become loose, then you may need revision surgery. The subsequent revisions and repeated revisions certainly are far more riskier and more complicated and may require more extensive implants. So where you have got an implant with a little pin like this, in a further revision surgery, we may have to put in longer stems, both on the femur and the tibia side, to have a better fixation. So imagine that will be along with more scarring around the soft tissues, and therefore it can cause more issues as you keep having to do repeated revisions. So a first-time revision usually is not a problem, but subsequent revisions can become more difficult. Yes, and they have higher complication rate, and success rate becomes less as multiple revisions are performed.
Okay, thank you. Moving on to the next question. Are the procedures suitable for someone with severe varicose veins?
So all depends on what you're asking the question about. Certainly, if you're talking about arthritis in the knee with your varicose veins, as I said, there are non-operative treatments we can do. Any of those are all suitable. Any operative procedures, obviously, one will have to assess where the veins are, how severe they are, and how much they increase the risk of blood clots and things. And that can be, as mentioned, something that can be assessed at consultation.
Okay, thank you. Alison asks, I've been told I have arthritis in both knees, but I also have a lot of pain in my shins. Is this likely caused by the arthritis in my knees?
Patients who have arthritis in the knees do get referred pain down to the shin. Now, without a consultation, I can't definitely say that your pain is probably from the arthritis, but whoever is you have consulted should be able to, consultant should be able to give you a much better clarity as to whether that is the source of your shin pain.
Okay, thank you. This attendee says, I will take it. You will take that one?
Yeah.
Okay.
So, Indra, you mentioned that you have an ejection fraction of 31. Would it be safe for me to have an operation? That indicates that you have got quite a severe heart condition, and it would be something that you will need to speak to your doctor first or your cardiologist. But my guess would be that surgery would be quite dangerous for you. And if that ejection fraction can be improved by any intervention on the heart, then certainly surgery may be possible. Two things. One, where you have got this severe heart problem, if you have to have surgery, it will have to be in a unit where there is backup cardiac and intensive and supportive care, which is certainly not available at Benenden. So I would suggest that if you are thinking about surgery, it may not be something that we can provide at Benenden, but certainly if you are looking for injection options, then we can definitely meet up and have a chat.
Okay, thanks. Marion asks, Does bursitis in the knee lead to arthritis?
So generally, bursa is something that is okay. So bursa is something that is there between the skin and the bone. So it is outside the joint, and there, when especially people do a lot of kneeling and a lot of whether carpenters, DIY, housemates, they all can get a lot of swelling down the front of the knee, and this is outside the joint. So the bursa is usually outside the joint, and it is similar. And the back of the knee, you can get a bursa, or you can get bursa associated with tendons on the side of the knee, particularly on the inner side, this side. So these are all outside the knee. Okay. You could still have an associated arthritis within the joint in association to the bursa. So that is not something that is happened because of the bursa, but it is in addition or association. You have already getting wear and tear going on in the joint. So there is no causal relationship between the two.
Okay, thanks. Karen asks, I have a meniscus root tear. I've been recommended to have a partial knee replacement, but would an arthroscopy not be more suitable? I do have a little arthritis on the inside of the joint, but the rest of my knee looks okay.
So, Karen, I'm not sure whether you've had a MRI scan to look at things more closely. If the MRI is showing only little arthritis, then one could consider debriding the meniscus, but generally with a root tear, the meniscus tends to slip out to the side, and then it is a sign of a failing joint, and the arthritis will possibly progress more rapidly that this tear has happened. These results of just repairing the root tear have not been that encouraging to stop arthritis progressing in the joint. So whilst you can do an arthroscopy and clear up the tear or tidy it up, it may or may not actually make the arthritis progression any different, and you may still end up needing a partial knee replacement in the near future.
Thank you. Next up is a question, I think this has cropped up before. What is the advantage of treating or not treating the patella during a total knee replacement?
So the patella resurfacing has its own additional complications. It can cause thinning of the patella, it can cause a fracture in the patella, it can cause damage to the tendons top and bottom. So you're adding additional complications to an already complex surgery. And therefore, and sometimes if I have noticed in some patients, technically, if the patella has been slightly made a bit more thicker, then it can intrude and stop people doing their flexion and cause ongoing pain in the front of the knee. So the advantage is that you have done everything and you don't need to go back. But the incidence of people who have not had a patella resurfacing is only in about 3% of patients. Sometimes one has to go back and resurface the patella because the pain is significant and causing problems. So it is a balance between thinking about more complications, and therefore it is a risk assessment and seeing risks to benefit, whether to leave it or to actually resurface it.
Okay, thank you. Elizabeth has been told that steroid injections can make arthritis worse, and she asks, is this really true?
So there is a possibility with steroid injections. You also inject local anesthetics, and there is some evidence that repeated injections of local anesthetics into the joints can cause some more damage to the cartilage, whether the preservative in the steroid itself can also cause some damage to the cartilage is a possibility. However, if the arthritis is already significant and it is causing problems, then it is, and no other treatment is working, then steroids might be a reasonable solution. So all depends. Certainly, it's not something that one would want to do in the very early stages of knee problems.
Okay, thank you. This person says, my x-rays showed mild arthritis to my knee due to wear and tear, and I was advised to go for physiotherapy. My question is, would the physio sessions provide just a temporary relief and, in effect, delay surgery, which is unavoidable?
So when you have mild arthritis, it is just the surface has got a bit of damage on it. You still have the gristle on the surface of the bone. So it is not a bone-on-bone situation. Replacement and the surgery such as that would be only advised when it is severe and bone-on-bone. So my advice would be certainly to have the physiotherapy to help strengthen the muscles, to prevent further damage on the surface of and wear down of your gristle, to help your knee carry on and work both with better pain relief and improved function. So that would certainly be what I would recommend if the arthritis is mild. I wouldn't recommend any surgery unless it's really necessary.
Okay, thanks. I think we've got time to squeeze one final question in. This person says, I'm celiac, which has led to me being osteopenic. Is that a problem?
So osteopenia and osteoporosis obviously weaken the bone, and people worry about it, but knee replacement is still a reasonable thing to do. It is important to just maintain good bone health and use supportive treatment and maintain your activity to maintain and slightly improve your bone strength over a period of time, but certainly knee replacement is not contraindicated in osteopenia.
Okay, thanks. Amazingly, I think we've got through all your questions. So thank you again for all of those, and thank you for being part of this evening's session. Mr. Thakur, if you could just move to the final slide for me, please.
No problems. Thank you for having me, Phil.
Okay. So listed on this final slide is a thank you for attending. We are pleased to offer 50% off the value of your consultation, available for a limited period using the code you see on the screen there. A callback from your dedicated private patient advisor. You'll receive an email with a recording of this session, treatment information, and some loyalty reward points via email, and also some an update on future events and health news. After this, you will receive a short survey at the end of the session, and we really appreciate it if you could take a moment to complete that, as it helps us to improve and tailor our future webinars to your needs. If you'd like to speak to someone to book your consultation, our private patients team is available this evening until 8:30 p.m. and from 8 a.m. to 6 p.m. Monday to Friday, and you can find the number on your screen there in the purple circle. And we also have upcoming webinars on a range of topics, including hip replacement surgery, varicose vein treatments, heartburn, and cosmetic surgery. And you can visit our website to sign up for those. All that remains for me to say is a very big thank you from all of us here at Benenden Hospital for tuning in this evening, and we hope to hear from you soon. Take care and goodbye.
Thank you. Bye-bye.